late tonight. I'll put in a commercial for my website.
I guess we can start.
Okay.
So on behalf of the CME, we're going to have the second of Sandy Eaton's talks on healthcare. And Sandy Eaton, if you don't know, is a longtime political activist and RN, and he gave a really informative talk last month, and I'm certainly going to give another informative talk this month. So
It'll be better this month. The technology is backing me up.
So I guess a round of applause. And
no ad libs. Very good. Lights, camera, action. I think everybody here knows me by now, so I'm not going to belabor that fact. 25 years ago, when I taught philosophy here, I used to bury all the students, all the participants in paper. And I'm really struggling to get away from that. I think I've become more ecologically conscious in the last 25 years. And so everything that we're referring to, the syllabus and every article that's referenced on there are readily available. And I'll have a website for you at the end. If you're able to do that. I do have a couple of things. I know everybody isn't online or have easy access to a computer, and I'll try to be flexible in that regard. But I'm going to try to keep that to a minimum. I know the title that was published by the Senate is about that this series is about single payer, and that's true, except that it's single payer embedded in a very much more complex picture. And I prefer to come at it from the angle of what are the contradictions that are driving U.S. healthcare, and it's certainly been changing rapidly for a number of years, and that seems to be only increasing the speed with which things are changing exponentially. And it's a very complex picture. Some people are doing better. A lot of people aren't doing as well. And what do we need to do? And hopefully this is the second in the series of 4 discussions. The fourth one will be focused on where do we go from here, because that's the most important part based on what we've seen here. And again, that's another way to state the contradiction that we're trying to grapple with. And I just want to start off quickly reviewing a few of the terms that I introduced last month, and at the risk of boring people, I'll try to move swiftly through that, but I think it's good to think about some of the frameworks in which we're looking at this issue. I always talk about healthcare justice, and I used to talk about access, affordability, and quality. I've discovered over the years that you can't talk about anything without equality as well. So you really don't have a just healthcare system if everybody's got an insurance card in their wallet, and hopefully people don't go bankrupt when they have to use it, and hopefully you don't die when you get in the hospital. I just want to make one point. Health insurance, while it's important, isn't the same as health care. A couple of years ago, some docs at the Physicians for National Health Program, I think it was David Himmelstein and Steffi Woolhandler, who were at Cambridge Health Alliance at the time, they're down in New York now, wrote the article for the New England Journal of Medicine. They talked about 45,000 people in this country die every year because they don't have health insurance. They don't have timely access to what they need. I think that in itself is a shocking statistic. Today I came across another statistic that said 17,000 people die because roughly half the states aren't expanding Medicaid to give them that coverage. Again, we're still just talking about insurance coverage, which often gives you minimal access and often still leaves you at great financial risk. And that 17,000 might already be included in David and Steffi's 45,000. Affordability. We're talking trillions of dollars in terms of healthcare in this country, and some are getting very rich because others are making sacrifices, and we don't think that's needed. Certainly, many of us, including the masters, and I should say again, sort of my usual disclaimer. I'm involved in or in the leadership of a number of organizations. I don't claim to speak for any of them. I don't think too many folks in those other leadership bodies would shy away necessarily, but I don't want them stuck with the credit or the blame for some of my outlandish proposals. Quality. Can you survive your encounter with the system? I mentioned this last time, in 1999, the Institute of Medicine came out with a report to err is human, and it talked about up to 98,000 people died unnecessarily in the country's acute care hospitals every year. Last year, ProPublica, another research group, did a study, and they said that at least 210,000 people die every year, and as many as 440,000 people in this country die unnecessarily in hospitals. There aren't enough staff there to take care of you. If you try to die, there's nobody there to prevent it. And when they find you, you're a little on the cool side, and that's not going to help. Or you might have fallen, and just the fall from that would leave you bedridden and bed-sore-ridden and infection-ridden, and you're a goner. So many of these indices about how you survive or encounter with the system require the right personnel there. I'd say nurses and a variety of support staff to make sure that you survive. And as you see, if you follow these numbers, medical error is now the third leading cause of death in the U.S. after cancer and heart, I guess. And equality, I think there's a classic statement from Martin Luther King that you see here that speaks for itself. Okay, don't mind me. Okay, as we discussed last time, a little under 18% of the nation's economy is tied up in healthcare one way or another. I forgot one stakeholder. Last month I started to delineate. We talked about all the different forms of insurance companies, and under hospital I talked about also, I include that under that heading, nursing homes, rehabs, clinics, et cetera, et cetera, et cetera. Just sort of an easy shorthand for me to refer to the institutions and their personnel that deliver actually hands-on care. The drug manufacturers, the people that make all of the IV tubings and Band-Aids and all of that. And what I forgot to mention last month was information technology. IT is huge. It was a big part of the Affordable Care Act. Literally billions are being put into priming the pump for IT. And I think a great temptation is to, of many hospital administrators, is to put their resources, take what the feds will give them, and put more of their own resources into that on the mistaken assumption that it's ultimately going to save money and deliver better health care. Bedside nurses will tell you that's not true. At least they haven't figured that out yet. And finance. We talked about GE being both a high-end device manufacturer, and it together with its German rival Siemens make all that heavy-duty equipment to diagnose and to treat. And GE also has its foot in the finance of healthcare, and it has a role in personal and family bankruptcies. I define healthcare reform as the conscious and systematic elimination of the profiteers. I don't know of anybody else that actually defines it that way. In my opinion, we really haven't had health reform yet in this country. And I mentioned last month that President Obama was right on the mark when he described the project. He stopped describing the project that the country was engaging in 2009 as health care reform instead of referring to it as health insurance reform. If we eliminate the health insurance, the commercial health insurance companies, we have a single payer, or what in my younger days we used to call national health insurance. You say single payer, and it's still confusing, I think, to a lot of people. And the formula that I like to use, because the original Medicare of 1965 has been contorted or warped or changed, strengthened and improved or enhanced Medicare for all for life, just to make it clear. If you get rid of the hospital corporations and those chains, and maybe take the VA system and expand it, we develop a national health service. That's ultimately, I think, the way that we have to go, because I see the way hospital care is delivered as being deadly, as well as lack of insurance. And then we have to deal with the drug manufacturers, the device manufacturers, and all of that. And at that point, I think my inclination is to take them over. I mentioned, until I discussed this last month, that in fact Sweden was public sector until only a few years ago, the drug companies. And now I get a headline service from Financial Times, and every day the major headlines under the health category are which pharmacy conglomerates are taking over which others. Bayer is negotiating with Merck, et cetera, right down the line. They're all in motion. We're talking billions of dollars here. This is becoming more of a dominant force. And again, quite frankly, if you start nationalizing these and creating a society, if you embed your just healthcare system in a just society, I would call that socialism. Just quickly, a little rundown memory lane, a little bit of history of major events in national history that have impacted. Can I lower this a little bit? I know we need the air.
Yeah, absolutely.
But I'm a little
go right ahead.
distracted. I try to keep a little bit. I mean, I love the air. Okay. Why did I bring up the National Labor Relations Act of 1935, the Wagner Act? Because it consciously excluded healthcare workers as well as domestic workers as well as agricultural workers. And I think that's a factor that we will see dealing with later on. Certainly in the New Deal, Social Security Act, things that came with that, there was talk of expanding that to health care for everybody. It didn't quite make it at that point. 1943, there was a national health bill in Congress. Never made it out. Started to make it out, but by the time in the mid-40s that it's... Oh, sorry, I keep hitting the wrong button. By the time it made it out, well, the McCarthy period was with us, labor was divided, and the forces weren't there to move anything forward. We mentioned that after the war, well, this country was building private hospitals and strengthening community hospitals across the country. The UK was developing their National Health Service. Labor came out of the war very strong and very dynamic and making a difference. By the mid-60s, between I think the atmosphere coming from the civil rights movement and others, pressure was building for some change in healthcare, and we have Medicare and Medicaid. Now, what that left us with in the paradigm at that time was sort of a multi-tiered system of healthcare in this country. If you were retired, most retirees would be eligible for Medicare, but not all. And who's been eligible for Medicare has sort of gone back and forth a little bit over the years. If you were in a marginal job, you were the working poor, or if you were disabled, there was Medicare. For those that were full-time, gainfully employed in stable industries or whatever, as they appeared to be in the mid-60s, you were expected to get your insurance through your employer, either unilaterally by the employer or negotiated with your union in a union situation. And that sort of went forward. But that, just one little aside, when Medicare first was promulgated, the Hospital Corporation of America had 4 hospitals in Tennessee. Within a couple of years, it had 200 hospitals across the country and around the world, and it was the largest for-profit hospital chain in the world. All the money, all the taxpayer money, the working class money going into healthcare went to healthcare expansion. That's important, but it also meant that the pigs were lining up at the trough and making out like bandits. People started complaining, policymakers and others, employers largely, that it was too expensive. Healthcare was becoming too expensive, so under the Nixon era, we saw legislation that would expand HMOs, and gradually that spread across the country and became dominant in California, Minnesota, and in Massachusetts by the 90s. And people's access to care and their choice of providers was increasingly limited. Another method was the diagnostic-related groups, starting initially for Medicare recipients in '84. It didn't come to Massachusetts till later in the decade because we had a special exemption from Congress. I don't know. Kennedy might have had something to do with that. I don't know. I just have to mention what I call the Clinton gambit: managed competition. Now, people say that, oh, gee, that's single payer, and I said no. It's a way to structure the insurance delivery system through regional insurance purchasing cooperatives. structured in such a way that the largest insurance companies could outmaneuver and outsell the small and medium-sized insurance companies and basically drive them out of business. So at the time, there was a backlash against this. On the one hand, the Senate Republicans came up with a package to throw into the hopper as an alternative to the Clintons' approach, managed competition with some employer mandate and so forth. And interestingly, it included the individual mandate, and I'm pretty sure many of those Senate Republicans from 1993 wouldn't be too uncomfortable with what's going on right now, except for the partisan factor and except for the race factor. But politically and ideologically, I think that's the direction things are going in. Another thing later in the Clinton era was the Balanced Budget Act of 1997. It devastated. It was the Medicare cutbacks. The home health services went belly up. Quincy's Visiting Nurse Association, 100 years old, went belly up in the late 90s because of balancing the neoliberal agenda, balanced the budget on the backs of the poor. And of course, there's the amendment to Medicare in 2003 under the aegis of George W. Bush, and with the help of the Republicans in Congress. And basically, it was to provide a pharmacy benefit to Medicare recipients in probably the most expensive and regressive way. If you used up to a certain amount, you had a donut hole you had to wait for, you would be reimbursed for further pharmaceutical expenditures beyond that. And the federal government was prohibited by law to negotiate with the pharmacy companies to get lower prices, even though the VA does it and other organs do it. And so it was really, they had a major regressive part of that. And of course, coming down, the Affordable Care Act, which we will spend next month dissecting. But I will say that the bulk of today's discussion will be on what happened in Massachusetts. And I think that's a prerequisite for getting to understand the Affordable Care Act, the Patient Protection and Affordable Care Act of March of 2010. Folks have probably seen the cartoon. We've got a wreck of a healthcare system in this country, and we tried every fix the insurance companies allow, and it still won't fly. With this deteriorating system, the for-profit chains started having more and more of a role, not only in insurance, but in the delivery of healthcare, of hospital chains, and so forth. This is Cerberus, the three-headed dog that guards the gates to Hades. Cerberus Capital Management has a big footprint in Massachusetts right now through healthcare and also through a number of other things. It has 10,000 apartments in Germany. It has the Reader's Digest. It has, it did have Chrysler and then ran it into the ground and sold it up for $1. It's been dabbling in a lot of, like all of the other, half dozen or a dozen major private equity firms have been messing around. Nevertheless, when they enter a healthcare market, the not-for-profits tend to behave like they do in order to not be undercut in the marketplace by them, and we have a mess. And the other side of that contradiction, some of us see healthcare as a human right, not as a source of personal and corporate aggrandizement. So we have a different agenda, and it's no great shakes. George McGovern at some point, whatever. Medicare for All is a simple shorthand way to describe what might be the way in which we deal with the commercial health insurance industry. Here's, don't take any notes, this is the, with the Massachusetts plan of 2006, sort of a schematic of some of the main highlights of it. It's actually more complicated than that. And here's what the House Democrats on Capitol Hill, this is a schematic of what their plan going into the hopper as we were heading toward March of 2010 and the final enactment of national reform. And after all of that, we still have something that won't fly, in my opinion. And again, people rail against the bureaucracy of the government. Well, I don't think there's any bureaucracy that beats corporate America, especially if they can find ways to cut corners, deny care, and make a buck on it. Now here's some crazy ideas. I don't know if folks know Elaine Bernard, who's over at Harvard Trade Union program. She's from British Columbia, originally active in the New Democratic Party and her union up there. And she's spoken over the years since she's been here in the States a number of times on single-payer health care. And she always tells the tale of how it used to be in healthcare in parts of this country and presumably Canada. You'd go to the local private fire company and you'd buy a placard. You'd put it in your window, and if your house caught on fire, they'd pull up. If they saw the placard, they'd put out the fire. If they didn't see the placard, there'd be some quick negotiating going on. Well, I mean, that's a crazy idea. It didn't catch on, and it sort of got poo-pooed because by the time, while you were negotiating, the whole neighborhood burned down. So that doesn't make any sense. Neither does privatized police, privatized food safety, and the logic here is that privatized health insurance and health care, again, at the best, it creates a multi-tiered system where you can get as much health care as you can afford. And it's, from a public health point of view, it's ludicrous. Just as ludicrous as from a public safety point of view, having your town burned down because some people were covered and some people weren't. If you, by the way, any hockey fans here? I don't know what time the game begins, but the Bruins game. But just about 3 years ago, I think it was 3 years ago, Boston was in Vancouver wrapping up the Stanley Cup playoffs for that year, and they won. It was a squeaker, as it always is, and the folks up in Vancouver were truly upset. They really thought that they deserved to win, and they didn't. So they were setting fires, rioting in the streets, and so forth. But this young woman up in Canada said, yeah, you got the Stanley Cup, but at least we got health care. And I thought that was something that we need to think about. Now let's talk a little bit about how we got to the Massachusetts miracle, as I'll call it. Back in the 80s, the second Dukakis administration, Mike wanted to run for president, and he developed an initiative to push healthcare reform, 87, 88. And there are various pieces of it. One piece of it, and again, personally, he's very much of a liberal technocrat, but he recognizes that single payer is the way to go. But as he read the dictates of the moment, he thought that the employer mandate, so he was trying to develop a quasi-universal system of health insurance for Massachusetts that was centered around the employer mandate, which means the state made every employer of more than so many workers make sure they provided health insurance of at least a certain value to their full-time workers or whatever. The only state that ever really got the employer mandate was Hawaii back in 77 or 78. They passed they tried to be a universal healthcare system. They got about 90% insured. It didn't quite work out 100% or even close to that because of the status of the economy. The big plantations were being moved off islands, and the tourist industry and so forth. So the typical Hawaiian person had 2 or 3 part-time jobs, and they all a lot of them tended to fall under the threshold where the employer is mandated to provide health insurance. So, but nevertheless, they'd get it up to roughly 90%, and that was part of the leading state up to that time. So if you heard the term employer mandate, that's what it refers to. But anyway, in 1991, Senator Ed Burke, he was a state senator. He was the Senate chair of the Joint Committee on Health Care here in Beacon Hill, and he pushed through, was the beginning of the Weld administration, the neoliberal agenda of deregulation, privatization, and this fetish of the marketplace is going to solve your problems. This magical thinking was out there, and he and some of the bigger hospital chains wanted to. They weren't chains at the time. So just some of the bigger teaching hospitals thought that they could deregulate hospital finance. Up to that point, how much people paid for insurance, how much hospitals charged, how much went to the insurance companies. A lot of this was fairly regulated. It just wasn't, left to the marketplace. That got deregulated by Chapter 495 in 1991. And initially, the insurance companies had the edge. And after that, I was walking a picket line on Francis Street by Brigham Circle outside the Brigham and Women's Hospital on December 7th, 1993. And the word came down the line. It was an informational picket line. The word came down the line that somebody just heard on the radio that Brigham and Women's Hospital and Mass General were forming a partnership. And I was the head of the labor program within the Mass Nurses Association at the time, and the wheels started turning. And Christmas morning, I woke up with a start, and I said, we're going to have to make some big changes here, because the changes are coming and we've got to get ahead of the curve. And we did, but the conglomerates, the hospitals started coming together, mass layoffs for the first time. Actually, we had a mass layoff at Quincy City Hospital, where I worked at the time, in October of '89, after job re-engineering consultants had come through, and we figured we didn't need so many people to work. During this period, the Jobs of Justice had a healthcare action committee, and we had a lot of fun with that. One day, we and all our allies got together and we strung a single strand of red tape all the way around the John Hancock Tower to try to get some media attention. I got a little, I don't think we got enough, to the fact that the health of the people was being held up by all the red tape of the commercial health insurance industry. I don't know if that message cut through very well or not, but that was sort of the locus point, the focus of our struggles was through the Jobs of Justice Healthcare Committee. Healthcare for All. There are groups called Healthcare for All in all of the industrialized states. I know California, Colorado, etc. And they're all for single payer, except in Massachusetts. At the fall board meeting of Healthcare for All Massachusetts, they decided to jump on the Clinton bandwagon and abandon single payer. Only Manny Weiner, president of Mass Senior Action, was the one no vote at that board meeting. And so the gaps began opening up between the people that were fighting for fundamental health care reform and single payer, and those that we use the word incremental. You get a little one step forward here, maybe two steps back here, and another one over here. We'll see more of that, how that plays out. So that was a problem. A number of groups, neighbor to neighbor and whatnot across the state, put non-binding local ballot questions out there for single payer, and almost all of them won handily in diverse communities right across the state. So after that, the folks that came together and were meeting in the Jobs of Justice Healthcare Action Committee decided that it was maybe we needed a coalition, a statewide organization, not on all the healthcare issues, but clearly focused on how we can win single payer for Massachusetts. And then that was how MassCare was born, and it's still around. It's the umbrella Massachusetts campaign for single payer healthcare, for single payer work in the state. Is it hot in here, or is it me?
It's hot outside, so.
Yeah.
Trying to get a happy medium here. Anyway, so in 1995 we founded MassCare, and a lot of groups, including the nurses, have been an integral part right from the beginning in that project, Mass Senior Action as well. Within a couple of years, we filed our first single payer bill for Massachusetts in the modern era. There had been an attempt back in the 80s with when John McDonough was the House Chair of the Healthcare Committee. He had championed a single-payer piece of legislation at that time. It didn't go anywhere, but he was still thought of as the spokesperson for the single-payer movement for a few years. That changed. He became executive director of healthcare for all of Massachusetts, and like I say, the ways divided in many ways, unfortunately, too sharply. The nurses had been in rebellion against the changes. I organized our first rally on the steps of the State House of RNs, LPNs, and student nurses in June of 1993. Remember, 1991, which I consider that bill, I think that the original sin of the modern era in Massachusetts healthcare, sort of opened it up and sort of institutionalized, if you can, the neoliberal approach. Bill Weld was already privatizing, the Republican government was already privatizing. Privatizations began under Dukakis, but they were, reached fever pitch under Weld and his successor, Paul Cellucci. Anyway, the doctors rebelled. Like I said, the nurses rebelled, and we put together a package of bills and started fighting them out at the State House that led to our safe staffing bill, which we'll talk about more later, and now our attack on hospital profits and the hiding thereof. A lot of the physicians rebelled. Some physicians from PNHP, the Citizens for National Health Program, as well as others. Bernard Lown, who was part of the group of physicians that got a Nobel Peace Award a few years earlier, trying to stop nuclear proliferation, nuclear war. So a lot of prestigious physicians came together and didn't know how to organize their way out of a paper bag. Some of us nurses joined with them and tried to give them a little boost, and others joined in. And they issued a statement in December of 1997, which was called "For Our Patients, Not for Profit." Put the profit question right up front. That was the way it was. That was a good start, and so forth. In 1998, we made a collective decision to put a question on the 2000 ballot that would straighten things out. So folks came together. Question 5 on the 2000 ballot talked about the need for a Bill of Rights, a managed care Bill of Rights for patients and providers. We talked about the need for a universal health system by a date certain, that date being June 30th, 1992, and that there would be a moratorium on for-profit conversions, taking any service or facility in Massachusetts that's not for profit and making it into a for-profit until a universal system was in place. There was a conscious strategic decision not to say single payer at that time. That did cause some friction later down the line. But the only health reform boat in the water really was the single payer movement that we've been building, so that didn't look like it was going to be a problem. We went down the line and during that period the Massachusetts Labor Party and others put local non-binding single payer questions on a number of ballots in communities in western Massachusetts and in the greater Boston area. And they all flew by, they all passed handily, they all passed under the radar of the insurance companies, so they weren't attacked, including in 2000. So in 2000 you had a choice. You could also vote on a single payer local question if you were in the right community. You could also statewide vote on this omnibus health reform bill. We were polling the statewide binding legislation was polling in the 70th percentile at Labor Day. The not-for-profit insurance companies put $5 million up, and we had round-the-clock attack ads till Election Day, and we lost by 2 points. But part of the attempts by the industry through the legislature was to come up with some legislation in July that would mitigate the circumstances and cool the jets of the coalition that was fighting for it, and the coalition actually did split in July of 2000 over whether to keep on fighting all the way to the ballot in November, or whether to settle for the Managed Care Bill of Rights and a promise of a study on single payer. Phil Mamber grabbed me and Rand and a few others, and we went up to the State House and we helped listen to the negotiations between the chairs of Ways and Means of the two chambers, and what came out of it was an agreement to pacify the single payer supporters. There would be a study, later known as the LECG study, after the biggest of the three consultants that were called upon to study how to get single payer in Massachusetts. I insisted that it come out early enough in the year 2000 to inform the elections of 2000. It came out December of 2000, and it did not show us how to get to single payer, but it did reveal a lot of things. And as I recall, it was around 39%, but I don't, of the healthcare dollar in Massachusetts was overhead. And that covers a lot of, from bureaucracy to marketing to executive salaries to you name it, rather than the actual delivery of healthcare to people. And that was, in itself, was dynamite, and I guess that was helpful, and we tried to use that moving forward. That was 2000. We gave the insurance companies a scare. They managed to circumvent the worst of their fears that year. In 2001, Blue Cross Blue Shield of Massachusetts, the largest not-for-profit, the largest health insurer in Massachusetts, created a foundation, Blue Cross Blue Shield of Massachusetts Foundation. And it started putting money into groups that agreed with it that the main question should be access to health insurance. We're not going to worry about health care. If you get the insurance, then everything's all set. So they changed the dynamic of the debate through that, and they also had annual stakeholder conferences. Well, I don't know if, I think we're stakeholders, but whatever. Mostly people with suits on and ties. And it was what it was called was Roadmap to Coverage campaign, and it was all about how do we expand insurance coverage, not how do we make sure everybody has affordable, quality care. And like I said, subtle. They hired a liberal think tank based in D.C. called the Urban Institute, starting in 2002 to help them with this, develop this process. And we were all shocked in October 8th of 2005 at a huge stakeholders conference that a lot of us snuck into, when the the Urban Institute policy wonk said, and I quote, "There is no way to achieve universal coverage in Massachusetts without the individual mandate." Because earlier that year, let me back up, the individual mandate was dreamt up by the Conservative Heritage Foundation in the late 80s, and it became an integral part of the Senate Republican counter to the Clinton proposal in the summer of 2003. It comes up again. Governor Romney proposed, threw that up like almost like a trial balloon, and everybody said, "Oh, that's a crazy idea, it'll never work here." And then the Liberal Urban Institute came out and said that's the only way we could get quote universal coverage, which is possible that way. And so we wound up in the late fall of 2005 with the liberal think tank and the conservative think tank, with the Democratic Party and the Republican Party all on the same wavelength, moving in this particular direction. One of my colleagues went up to the Urban Institute wonks after the adjournment of that session and asked, "Why didn't you consider single payer?" And the answer was very straightforward. We weren't allowed to. Yeah. So single payer was off the table in Massachusetts in 2005, just like it was off the table in Washington in 2009, which is reflective, I think, of the political influence of the, at least of the health insurance industry and probably other sectors as well. Okay, so in March, in the syllabus, there are 3 articles that and again, there's no quizzes, no final exam, but if you're curious, and I'm not a policy wonk, I'm a political activist, but there are 3 articles in there taking a look at Chapter 58 of the Acts of 2006 and the impact on it. I'm only going to bring out one piece which I brought up. Well, there was an article that was published by MassCare, and actually it was a slideshow produced. No, it was first a study and then made into a slideshow by MassCare and the Massachusetts chapter of Physicians for National Health Program, sort of analyzing in maybe 2010, 2011, the impact up to that point of the Massachusetts plan. In the fall of 2008, Bob Blendon over at the Harvard School of Public Health and his associates published an article in Health Affairs, and this got headlines, the Globe, everybody, that people in Massachusetts overwhelmingly loved the Massachusetts Health Reform Plan. If you read through it, maybe about page 8, there's a section that'll point out, it's not highlighted, but it'll point out that 50% of the people who were directly impacted by that felt they were worse off than they had been before the passage of Chapter 58. Only about 20 or 25% thought they were better off, and the others didn't think it made much difference one way or the other. So that wasn't the headline. The headline is the average person on the street with a good-hearted, liberal Massachusetts. Oh yeah, I think it's a great idea that we're going to get coverage for everybody. Period. And there's been a lot of other sleight of hand in terms of who you, which consultant you get to write your study to say what you want it to say. All through this, before the enactment, during the enactment, since the enactment, and so forth. Anyway, the basic premise is shared responsibility, skin in the game. This is a Republican concept going back to the Heritage Foundation. That healthcare is so expensive because people use it too much, people demand too much, people want too much of it. That if people had to pay for it, they think twice before they access the healthcare system. And hence the whole drive, this is the neoliberal approach, the whole drive toward deductibles, co-pays, co-insurance, every which way you can to make people pay themselves out of their own pocket under the excuse that they'll be more prudent in the use of these health services. This thinking actually predated the expansion of managed care. Even when it spread really across Massachusetts in the early 90s, it was the argument was that people need to feel the sting, so they don't use it. As if you pick up a newspaper and there's an ad or a special on gallbladder surgeries at Hospital X this week, or rush right in. As if people have a choice about that. The other thing about Chapter 58 is it was needed to get a $368, I think it was, $1 million Medicaid waiver for 2 years from the Bush administration. So Chapter 58 had to pass muster of the Bush administration in order for people who are always cash-strapped, and even more so now than then, but in order to do their budgets. So there was tremendous pressure at that point. April 12th, 2006. This is the stage at Faneuil Hall. A few of us were outside leafleting, and every suit in the Massachusetts healthcare industry was inside. And if you look at the who's at the desk, sure, of course, it's Governor Romney. I adamantly refuse to refer to that as Romney Care because look who's standing right behind him. I don't know if you can make it out. It's a little fuzzy. That's Ted Kennedy. The Sal de Macy before he went to prison. That guy right there, Ron Mariano, beat me in a special election in 1991 for state rep in the 3rd Norfolk District. I ran as an independent. It's a long story there. He hates the Massachusetts Nurses Association because he claims that they put me up to run against them. Actually, the Communist Party put me up to run against them. But that's another story. I didn't tell him that. Let's see. Travaglini, who was the Senate president at the time, who actually was the Senate co-sponsor of the single-payer bill up until he rose up in the leadership of the Massachusetts Senate. So personally, I'm a little cynical. I do think our single-payer bill, we've always had it going through ever since at least '97. We've peaked with maybe a third of the House and a third of the Senate signing on as co-sponsors. As they tend to rise in leadership, they tend to disappear. It's my personal strong belief that we're not going to move a fundamental piece of legislation through the Massachusetts House, at least, until we have 10,000 people with firebrands and pitchforks going up Park Street to the State House to drive out with the health insurance lobbyists. I think we need a fundamental shift. And I think that corresponds, actually, to a lot of other struggles coming together. What we've seen is that as the healthcare has been converted into an assembly line, is not only layoffs, but as far as the patients are concerned, you put your light on. Now, it got so bad in California at one point, somebody was bleeding out post-op that they picked up their phone and dialed 911 in order to get a nurse to come in. And I think similar things I've heard have happened around here. So again, the biggest single factor in a hospital budget is the labor cost. It's a service, it should be. And certainly the first thing they hit is, well, aside from giving you too little linen, too few snacks in the refrigerator for the patients, et cetera, is finding ways to lay off and speed up the survivors. And we've got this campaign going. There's a commercial. I'll talk more about that later. It's interesting that a lot of organizations, even for-profit organizations that provide health care, like Tenet, sounds very religious, or like Caritas, the Archdiocese of Boston's hospital chain, which was taken over and converted to a for-profit chain called Steward, all very kindly. But of course you've got the three-headed dog, Cerberus, behind it all. I don't know if anybody's been involved in union negotiations at work. It's almost a dance that you perform. First time out, the management always comes in with a dog and pony show to tell you how poor they are, how desperate they are, et cetera, And we've learned to be passive aggressive. We have our own dog and pony show, which next session we show them all about how unsafe staffing is and the deplorable conditions, and that something needs to be done about it. This also reminds me, the current executive vice president for strategy and policy at Steward Healthcare came from the DeBell Patrick administration. He was the, quote, healthcare czar up until maybe 3 years ago when he came to the private sector. Coincidentally, the St. Elizabeth's Hospital in Brighton, its CEO, Steward person, appointee, hire, or whatever, a couple of years ago, went into state government as the Executive Secretary of Health and Human Services after Dr. Bigby was shown the door. We talk about you go down to Washington and the Pentagon and just swapping back and forth between governments and the military and the political leaders and so forth and so on. We've got that in healthcare. This incestuous relationship in healthcare. This was on March 1st last year, 2013. Things were coming to a head. We had 4 different groups of nurses from 4 different hospitals at the table at one time, and we were doing joint bargaining across and not getting anywhere. We had been about 1.25 years into negotiations at this point, separately, and now we were all together. Doing more with less was their theme. Our theme, of course, was patients deserve more. In other words, we're flying in the face of the neoliberal agenda. And here's one. Jill, at the time, worked in our emergency department at Quincy Medical Center. The best thing about a strike situation, ideally, is that it builds a very cohesive workforce where people that never said boo before are talking to you and very expressive about their concerns and their needs and finding creative ways. So she wasn't walking out, she was standing up for the patients as well as for the nurses themselves and the community, because we need a hospital in that community, but we also need a hospital with safe care in that community. I'd like to say that we had about a 94-95% rate of members actually voting to authorize the strike or take, secret ballot. That's pretty high. You have to consider in hospital you've got an awful lot of part-timers, a lot of per diems, flex people, and so forth. There are always some people out on sick leave, maternity leave, whatnot. But we got that 200 to 13 was the vote, and we knew pretty well who the 13 people who voted against the strike were. You just know everybody. Fine. And I'm proud to say that not a single person in the bargaining unit, no matter how they voted, crossed the picket line, and most of the people that voted, whether we suspect voted no, were out there on the picket line with us. So I think that was a tremendous show of solidarity and strength. And we finally, in November of last year, after 23 months, settled a contract. Anyway, I won't get into the details about that. Here's another colleague of mine, Ann. Just so people don't get to think that it's only the for-profit hospitals or the for-profit insurance companies that are the villains. Under the sponsorship of the Jobs and Justice Healthcare Action Committee, which was recreated more recently to make sure to try to get more labor and working-class organizations involved, we had a rally where the old Sears building used to be over on the Jamaica Way, the Fenway, Riverway, I guess. And so we had a big rally there, and she wanted to make sure that Blue Cross got targeted for their behavior. And as my colleague, who's a couple of weeks away from retiring at the University of Massachusetts Medical Center, she's for many, many years an IV nurse. She just got laid off just before she could start collecting. I don't know, I trust they can negotiate something for her, but they just wiped out the IV department at UMass Memorial, both major campuses there. Joint. And at North Adams Regional Hospital, last month, as you by now know, the CEO called the staff into the cafeteria one afternoon and said in 3 days we were locking it down, we're out of money. It turns out, with some investigation, that they had made all kinds of bad real estate investments and all kinds of gimmicks. Remember when we talked about Bill Burton? We talked about all these community hospitals, and they all tended to have boards of directors peppered with bankers and real estate folks and the local bourgeoisie. Well, here the local bourgeoisie screwed up royally, apparently, and we're still waiting for the prosecutions to begin, because there's a law. There are at least a couple of laws in Massachusetts that say that, well, first off, 90 days notice for shutting down healthcare services because the community has to make allowances. And there's another law that says 60 days for any employer of more than 50 people. And there are probably 1,000 other regulations. But if powers that be, let them get away with it. However, down the street in Pittsfield, Berkshire Medical Center is going to pick up emergency services, and hopefully by the middle of the summer we'll see if we can't pick up the full service of that. Our researchers at M&A did looked at the books, and we feel that it is a viable institution fully, and there's no excuse not to reopen a full-service hospital, even if it's under the aegis of the next hospital down the street. Well, that's the way things are going, but the community needs it. The pediatric unit at Morton Hospital in Taunton was shut down last year. The DPH will come. Right now, the DPH has the power, Department of Public Health, if anybody asks, to hold a hearing if any services are being cut back. But it has, it has the authority to issue a recommendation. It has no power to enforce that recommendation. So, yes, the community said we need this pediatric unit. There was more than adequate evidence shown, and they And the Department of Public Health issued a statement saying, yes, this is a necessary community service. And Stewart went ahead and shut it down anyway. So here's a commercial. Anybody got any free time on a week from Wednesday, May 21st, feel free to drop by the State House. We're pushing an agenda. We did a little research, and a couple of weeks ago we had a press conference at the State House, and we had poor Wally Soper from Jobs with Justice dressed up like a cat. It's huge, a little stuffy inside the building, but dressed up in this huge big hat, with a top hat on and money's falling out of his pockets and so forth. And he was the fat cat hospital CEO, and he went around and he delivered Cayman Islands beach blankets to each of the legislators. We all helped. There's a lot around. So we delivered that. But as part of that process, and what we were reviewing, what we were shining a light on, is that our researchers surprisingly discovered that maybe as many as 40 Massachusetts hospitals have accounts in Cayman Islands and other offshore places. Here, I don't know, it's a little fuzzy, you can't see that. I'll be glad to make copies at some point. But, including such safety net institutions as Boston Medical Center and the Cambridge Health Alliance. So, what gives? The for-profits, incidentally, Stewart and Tenet is back in Massachusetts. They don't happen to be on the list. They ship their profits off to corporate headquarters somewhere, but all of these not-for-profit hospitals shouldn't somewhere. Now, as we understand it, they have to report that to the feds, that it exists. They don't have to tell anybody how much is in it. And especially going into budget time, we thought they were particularly vulnerable. So we were glad to stick it to them and say, okay, well, we're pushing legislation that is going to make transparent everybody's accountings. And we're also going to have a provision to claw back profits of more than 8% and CEO salaries that are more than 100 times, not salary, but compensation packages. Most of the compensation doesn't come in salaries that you can see. More compensation package more than 100 times that of the lowest paid worker in that facility. And we'll see how they like that. But anyway, it's down and dirty, folks. And there's the bath towel. I'm doing a TV show down in Sandwich next Monday, and I got to remember to bring. I have out one of these towels to show on the cable TV to inspire the Cape folks to get up in arms. And that's mass care, like I described earlier, as an umbrella. A lot of organizations are part of it. What I think is essential is that mass care turn its face to the working class. I think I mentioned this last month. We had an advisory board meeting, I think it must have been late winter 2007. I was still chair. I did a 2-year term as chair of mass care. And Mel King, I think it's a 10-term city state rep, almost mayor of Boston in 1983. Marvelous and powerful community leader and spokesperson, African American, spoke at that advisory board meeting. He was the only person of color in the room. We had all kinds of great doctors and nurses and you name it, from every suburb of eastern and western Massachusetts. But the working class wasn't very well represented, including the African American community and other people of color. He said that you're not going to make any headway if you don't have folks who are most severely impacted by the crisis in healthcare, who are most suffering, involved in giving leadership to this. And so it's been a bit of an ideological struggle. We do have a decision made a couple of years ago to organize work in the Three Cities campaign, we call it, Springfield, Worcester, and Boston. It's been so far halting off and on in the other cities, but folks are trying. In Boston, finally, the Boston chapter of the Committees of Correspondence of Democracy and Socialism, which is affiliated with MassCare, said, well, damn it, we'll take it on. Somebody's got to do it. And so we've been trying We've had several meetings. And as a matter of fact, I've been doing a monthly newsletter. It's up here. Everybody feel free to help yourself. I'll take two if you know somebody I'd like to give it to. And again, it's on Sea Change Bulletin is the website that I've had since 2000. Bill Bumpus from the Wobblies, who was active with me in the Labor Party in the 90s, Massachusetts Labor Party. As a matter of fact, the last time we had a meeting, which I think was in early 2001, the folks in the room appointed me the Labor Party's official healthcare spokesperson, which was nice, but we never met again. So, but I have got technical assistance, and I do have a website, seachangebulletin.org, on which I put newsletters, on which I put syllabus for this course, on which I put links, if they're not already on the syllabus, to articles, or post other articles that are very germane to what we've been discussing and what we will be discussing, and links to a variety of important organizations who also have much information of their own to share with you. So please, feel free. My throat is going dry. I'm going to stop for a minute and see if anybody has anything they'd like to say, or not. I apologize for much of tonight being a repeat of last week, but there were folks who couldn't be here last month, and I wanted to sort of wrap it all together. And next month we'll be doing the same thing, but building it up on the federal level, how nationally we got to where we are today. And the final session will be where, at least I think not me alone, I think we need to go, what forces we have to bring to bear to eventually create a just healthcare system embedded in a just society. And I really, really recommend the reading stuff for today. If you want more policy information about these things, the links are there. If I hear nobody else, I can get something cold to drink and go home. Would you like some lights? Okay, thanks.
I guess something to just bring up, if no one's gonna bring it up. We have an email list, and we do need to pay our rent and hopefully get more new books in and so on and so forth. So if you have a few dollars you can spare, that would be excellent. And the bin is right up there.
Tilly.
This is